Okay, so my name is Dr. Angus Nisbet, and this is the Consciousness Lecture 2020 for the Neuroscience and Behavior module. So I'm going to switch the video off. I hope you get something out of the lecture, and I'd be very happy to take questions. So I'm just going to switch to sharing screen, and won't be a second. And we'll switch the video off. So that's that. And hopefully you will be able to see my screen. I think I'm going to keep it on this mode so that I can see what slide is coming next. Let's just check that we're recording. I think we are still recording. Let me just double check. I'm going to stop the screen sharing. Yeah, we are still recording. Okay, fine. And let's go back to screen share. Okay, fine. So consciousness. We think we all know what it means. It's sometimes, when you think about it, a bit difficult to define. So we're going to start with the definition, and then we're going to talk about the medical aspects of consciousness, the stuff you really need to know for your neuroscience and behavior module. We're going to talk about the what's going on in the brain during consciousness and the relationship between brain structure and consciousness, and also brain function, which of course goes together with the structure. And then we'll get into a little bit of philosophy at the end. And there'll be a little bit in the middle about disorders of consciousness, which is also important from a medical point of view. Things, the sort of thing you need to know. So there might be some questions on disorders of consciousness, and the basic medical assessment of consciousness is something you also need to take on board, as it may come up in an exam question. So with definitions, it's always good to start with the etymology, the makeup of the word, con meaning together and skios or skio meaning to know in Latin. So one could say that it literally means, or etymologically means, knowing with or knowing together, or possibly sharing knowledge with another, although I think that's probably less of close to the meaning. If we look at the Oxford English Dictionary, which is also another good place to start, we get the state of being aware of and responsive to one's surroundings. And I think that's actually very good from a medical perspective. It gets the sensory motor aspect of consciousness, and it starts to hint at one of the ways that we assess consciousness in the emergency room, which is where it's most often assessed, and of course in the anaesthetic room. John Locke was an English philosopher, a country doctor who was a bit of a polymath, was actually trained by Thomas Willis in part. And he was interested in the human mind. He wrote what was known then as a philosophical treatise on the human mind, called An Essay Concerning Human Understanding. And he talked about perception rather than consciousness, but really it's a very similar thing. And he talked about perception being what passes in a man's own mind. And of course, mind is arguably an alternative word for consciousness. But in fact, his concept, the concepts that came about in this book that he wrote, really give rise to the modern concept of what we describe as consciousness. He really didn't seem to include emotions in it. If we sort of skip forward to recently retired philosopher, Canadian philosopher, but who worked at University College London, slightly pretentious in the way he talked about things, and certainly his definition of consciousness would appear pretentious. He called it the appearance of a world. And in some ways, it gets at the idea it's just sort of everything when you wake up, the appearance of everything around you. but it has the disadvantage in definitional terms of omitting the inner world of emotions and perhaps the inner world of imagination. But in fact, if you read his theory, his book, his papers, he did include these. And he came up with a concept for consciousness known as actualism, if you're interested, but we haven't got time to go into that. Probably the best known and most quoted definition of consciousness these days is that of Thomas Nagel, another philosopher, an American philosopher, who wrote a very interesting paper in 1974 called What It Is Like to Be a Bat. And he was getting partly at the problem of trying to sort out how we can know, in fact, how we can't know what the consciousness of another animal is, and certainly not even another human, certainly not another animal. And he came up with this idea of saying that if you're conscious, then it's something that is like to be that creature. So that was the idea. But the problem with this definition, although everyone tends to quote it, is that the word like implies that it's a comparison with a previous experience of consciousness, and therefore it starts to get circular. But this is the problem with all definitions of consciousness, and we'll talk about why that might be. I think my preferred way of thinking of consciousness, and again I will accept that it is a circular definition, is to use the word experience, because I think the word experience doesn't have any sort of funky connotations or new age connotations, but it just basically encompasses the whole area of anything that you are conscious of. So it's another word for consciousness. So again, as I say, it's a little bit circular, but the property of experiencing anything or everything at all, anything at all or everything. And human consciousness, obviously, the property of experiencing sensations, perceptions, thoughts, and emotions, because that just about wraps up all the things you can experience. I think you can challenge me on that if you like. But as I've said, it substitutes the word experiencing for consciousness, so it's still circular. So why is it that all these definitions tend to end up with a circular statement of some kind? And of course, the reason is that consciousness is rather the vessel that everything else is contained within. You cannot describe anything as existing or anything having any properties, any feelings, any perceptual component, or any cognitive component, unless it's part of consciousness. And so consciousness kind of, as Ted Honderich talked about in his appearance of a world definition, it's basically just everything. Everything that you experience and feel. And so it's very, very difficult to define it in terms of any other features. In other words, it's a very fundamental property, which is interesting, and we might come back to that. Well, how do you know someone's conscious? Well, you partly think about what you're like when you're conscious. And you know that when you're conscious, you're looking around in your environment. In experiencing it, you will tend to react to it initially by orientating with head and eye movements towards whatever it is that you're conscious of. This gets across actually another philosophical idea, the philosophical idea of intentionality. That doesn't mean what intentions you have. The philosophical meaning of intentionality is the fact that it's your consciousness is about something. It's always focused on something. It's your relationship to something in the world. And so this idea of aboutness. And so this is why consciousness produces eye movements and head turning. And also if there's a threatening situation in the environment, there will be protective or defensive movements. So you can often test that by bringing your hand in quickly across the visual field in a way that might be threatening to a patient who is drowsy, and you're trying to test their level of consciousness, and you see whether they blink when you bring your hand towards them. And also we have to think about consciousness also involving spontaneous voluntary actions. Of course, the whole basis of voluntary action is that it is a conscious action. You're aware of what you're doing, and therefore it has some deliberate component to it. And so we can look out for deliberate voluntary actions on the part of the patient who we're assessing consciousness in. And we're going to talk about that. But we can talk about that really under the categories of usually vocalization, and then locomotor movements and other movements such as grasping movements, etc. Vocalization is another way of testing whether someone's conscious. Of course, you can vocalize when you're unconscious, but usually just a groan. So it's a question of how precise or how complex the vocalization is. Does it contain language, and how complex the language is, and is the language orientated and relevant to the environment that the patient's in, so you can get an idea of the level of cognitive functioning or the level of consciousness. We've touched on the problem of other minds in the Thomas Nagel definition, the problem of not being able to be absolutely certain whether anyone else is in fact conscious, or what it's like to be them, which is sort of the same thing. So if you can take a very skeptical philosophical position and believe that yours is the only consciousness, and that everybody else is a zombie or part of a computer program, depending on which particular branch of skepticism you want to adapt. The question of zombies is interesting philosophically. Sorry, I'm going to go back to that slide. Zombies are the idea of a philosophical zombie, or the philosophical idea of a zombie, is basically a human being, as it were, who acts in exactly the same way as a conscious human being, but is unconscious. The question of whether they're conceivable or not, or whether they're feasible, slightly two different questions, is one of the ways that philosophers get at the idea that consciousness perhaps adds something. And if you can conceive of a zombie, then consciousness adds something to the behavioral input and output of an animal. Broadly speaking, if one thinks of defining consciousness, you can either take an objective perspective, which is what we were doing when we were looking at behavior, or a subjective perspective, which is describing your own consciousness. And of course, in medicine, we tend to take an objective perspective. We do actually ask the patients sometimes about the contents of their consciousness, but in assessing the level of consciousness, what we're really looking for is the ability to respond to stimuli, the spontaneous movements, the ability to speak, and the ability to orientate in time and place. And these form the basis of the Glasgow Coma Score, which is used in the emergency department in patients who come in drowsy or comatose, and indeed in the neurosurgical department, and to a lesser extent in anaesthetics. And the things in red there are the things that we test predominantly in the Glasgow Coma Score. We test pain, so we administer not too unpleasant stimuli, but we might squeeze the nail bed in a very, very drowsy patient to see if they respond. Of course, if they're not that drowsy, you don't need to do that. You can just touch them, and you can ask them to respond and see if they're obeying commands, and so on and so forth. Again, in a very drowsy patient, you might sort of make a clapping sound in their ear and see if they respond. The way you test their response, you look at their verbal response, their behavioral response, and their eye movements. So those are the ways we test on that. We'll have a look at the Glasgow Coma Score in a minute. We don't generally in medical practice test olfactory and gustatory stimuli, apart from as part of the full neurological examination of the cranial nerves. If we think about the subjective, if you're assessing your own consciousness and what components there are, you can break it down into a number of different things. So there's tactile sensation, of which there are different components, including touch and temperature and so on and so forth, and pain. There is your ability to perceive in an auditory fashion or in a visual fashion. The contents of your auditory world and your visual world. And then also there's other things going on as well as your senses. There's internal feelings in your body, some of which are related to emotion, some of which are just detecting movements of body parts and so on. There's the experience of memory, there's the experience of thought processes. So that could be something complex like mathematics, or it could be planning for the future, or it could be conceptualizing, as you might be doing now as we're thinking about consciousness. It might be thinking about yourself in relation to the world out there, or to others out there. And then also there is also the voluntary aspect of consciousness, as I like to call it, which is the sense of agency, the sense of being in control of your actions, being able to decide consciously to act, to speak, or to attend to something, or indeed to think. And some people have described thinking as a type of motor activity without movement. So all these things are components of consciousness. So there's sensory components, which at their very basic level are just sensations, but a perception is a much more detailed construction from your senses of the object that you are trying to recognize, or if you've recognized it as a member of a class of objects, you have effectively perceived it, and that involves quite a lot of downstream cognition rather than just the, for example, the pure visual cortex involvement. Right, let's move on to what we require to be conscious. Well, we have to think about the brain. We know that consciousness, it's fairly obvious to most medical students, I think, that the brain is associated with consciousness. It's not been obvious to everyone throughout history, but Hippocrates got the idea, as did Galen, although Aristotle, I think, wasn't of that view. I think him, along with a number of other Greek philosophers, thought that the brain was some kind of ventilation organ. Anyway, so it's associated with the brain. So what sort of state does the brain have to be in? Well, we know that the cortex, the cerebral cortex, I'm going to come to this in a bit more detail, is important, but the cerebral cortex has to be activated, and it has to be activated via the thalamus and the brainstem, the ascending arousal systems, which used to be called the ascending reticular activating system. We now tend to think of them in terms of individual neurotransmitter arousal systems, such as the 5-HT and the cholinergic system and the histaminergic system and so on. There needs to be connectivity between various areas of the cortex so it can talk to itself, as it were. There needs to be input from the outside world into the primary sensory areas of the cortex so that those inputs can be processed. So, for example, sensation can be converted to perception. And then, generally speaking, there does need to be some kind of output, although there's a question of whether output is necessary for consciousness. But usually consciousness involves some kind of response to the environment, as we've just been talking about when we've been talking about assessing consciousness in the drowsy patient. There's certainly in human consciousness, there is cognition as well as perception. There is more detailed cognition, and there's usually an emotional background component. Even though you might not be feeling emotional, there's always some emotional tone that's applied, even if it's, oh, that's interesting. The sort of interest factor, the salience factor, or the boring factor all contribute to the emotional tone of any particular stream of thought. And of course, there's all those different cognitive areas I've listed there. Language, representation of space and time, thinking spatially and temporally. We can't really think any other way apart from mathematically and perhaps linguistically, logically. Integration of awareness. So that's really categorizing, working out meaning, binding experience, one experience to another, and relating that to memory and so on and so forth. So those all require to a certain extent a bit of output, a bit of processing, as well as the input, the connectivity and the arousal that we've talked about. This is just to illustrate, just as a sort of brief break off here, that consciousness, as William James described, is like a stream. William James was an American psychologist at the end of the 19th century, and he coined the term the stream of consciousness. And the idea was that each thought is partly linked to the thought before and partly linked to the thought that comes after, and it gradually fades, but it's continually flowing. And each set of thoughts is quite fresh and new. You've never had this moment. You've never lived this moment before. Every moment is slightly different. And this is someone looking at a Braque painting and going from Braque to Barak to, I can't even read, but there's a whole series of associations, which brings to mind Freud, of course. So that's just to really emphasize that consciousness is an active process. One of the questions you might ask is, how far down does consciousness extend into the tree of life, as it were? And I think most of us would accept that a dog is conscious, and to a certain extent a cat, although I think most of us would think that the cat's consciousness is perhaps not quite so rich as a dog. But then what about a mouse? And if a mouse is conscious, what about a fish? Seems to sort of get excited and thrash about when you sprinkle food in the fish tank, or when you disturb a shoal of fish, they seem to be reacting. They have a behavioral output. What about a worm if a fish is conscious? Certainly worms seem to respond to pain, but are they conscious in some way of that pain? Do they have a simple form of consciousness? And then, of course, we move on to plants. And this is an example of a Venus flytrap who's trapping an insect. So we perhaps can think about insects first. But does the Venus flytrap get any intrinsic satisfaction from snapping closed on a fly? Does it have any consciousness? And people would generally say, well, of course not. But one of the interesting things, of course, is if you look at plants and you do a time-lapse video, and you watch them grow and you watch them move towards the sun and react to their environment, you just begin to wonder whether maybe there's some kind of slow, very simple form of consciousness, although most people would, I think, reject that idea. I like to think of single-celled organisms, amoeba, and this is a flagellated organism called Euglena. The reason I like this one is this organism has chloroplasts in it, so it's kind of part plant, part animal. But single-cell organisms do tend to move towards favorable environments and away from unfavorable environments. They're living. If you watch them, they seem to have some kind of innate, and I put this in inverted commas, curiosity about their environment. They seem to explore. They seem to be driven by some exploratory drive. and they seem to be sensing their environment. So the question is, do they have some simple form of consciousness? And some biologists and philosophers would say yes, they perhaps have some kind of proto consciousness. Well, if you're going to say a single cell has consciousness, what about a single-celled organism? What about a single skin cell or gastric parietal cell or muscle cell? And then it starts to get a bit more tricky. And what about a bacteria? And of course, a virus, and that I think is the SARS-CoV virus there. So it's these are imponderable questions, really. Well, they're ponderable, but they're not answerable because of this so-called problem of other minds. We can't ask the fish or the cat or the dog what it's like to be them. Of course, the other thought is, well, we know humans are conscious and we can talk to each other. We think we're all conscious, but how far down the developmental tree, as it were, or the developmental continuum, does that consciousness go? Is the fetus conscious? And I think most mothers in the third trimester of pregnancy would say definitely yes. But how do we know? And if a fetus is conscious at that stage, what about at the earlier stage of, let's say, 16 weeks or 10 weeks or 4 weeks? Is a zygote conscious? Is a fertilized egg? Well, that is a fertilized egg. And so, again, we have these rather imponderable questions. The next big set of questions, of course, and we are getting a bit philosophical here, is what about non-living things? And one big question at the moment, this is actually, it's obviously a smartphone, I think it's the iPhone 12, and this is a quantum computer. So would a quantum computer that relies on quantum processing perhaps gain consciousness? And what about robots that respond to their environment and so on and so forth, and have been trained or have been programmed to perform deep learning? So this is a big question at the moment, whether artificial intelligence will ever become artificial consciousness. So AI, will AI become AC, or some people would call it strong AI? And there is debate, but a lot of people do believe that eventually, when things have achieved a certain degree of complexity in their functioning, and they have the capacity to learn as a result of deep learning algorithms, which are based on, in fact, how the human occipital cortex works, that they might become conscious. And so people are actually starting to write ethical manuals about how computers will have rights, because if they're conscious, they will potentially experience pleasantness or unpleasantness, pleasure or pain, and so on. I personally think that consciousness goes with life, but that's certainly not a universally held view. So let's get back to medicine, away from philosophy, and think about different states of consciousness. Obviously, there's physiological altered consciousness, states of sleep, and deep sleep, which we call slow wave sleep, is, as far as we know, not associated with consciousness. But we do know that dream sleep is associated with consciousness, and that mainly occurs in REM sleep. We've also got altered states where consciousness can be very, very different with psychedelic drugs. And sometimes there's distortion of the external world with some psychedelics, particularly a psychedelic called 5-methoxydimethyltryptamine, which is known as the Everest of psychedelics because of its potency from a psychedelic perspective. Can induce an almost purely internal state where the external world doesn't seem to register. So that's very interesting. That starts to get like a dream state. General anesthesia produces a state we think very similar to deep sleep with unconsciousness, although of course you can regain consciousness during anesthesia if the anesthetic dose drops a little bit. And then there's damage to the brain that can result in usually global damage to the brain, but there are certain areas that are susceptible to causing, if they're damaged, they tend to result in loss of consciousness. So the brain stem, for example, because you lose the activating system if you damage the brain. But big or global damage to the cortex, for example, after a seizure. So that's when I say damage, that's a temporary disruption, or a head injury, or infection such as encephalitis or severe meningitis with irritation of the cortex, and big strokes and raised intracranial pressure and so on and so forth. We're going to talk about PVS, persistent vegetative state, which is now tend to be called the unaware wakefulness syndrome, and the minimally conscious state, which is a partial unaware wakefulness syndrome, where there is some awareness, some limited awareness. And the locked-in syndrome, where consciousness is completely preserved, but the output, the motor output, is damaged in some way, and we're going to talk about that. Slow wave sleep. This is an EEG. It's actually from a polysomnogram, but these are EEG leads. These two black leads here, these are the eye movement leads, but they're actually showing shine through of the big delta waves, these slow waves that are less than 5 hertz and of high amplitude, characteristic of slow wave sleep. You also get that in general anesthesia, and you can get it in coma as well. Stage 2 sleep is characterized by spindles and K complexes and sharp waves. And sometimes you can have fragmentary dreams in stage 2 sleep, and there are often little arousals to partial wakefulness as well. And then we have REM sleep, where the EEG looks very like wakefulness, which is high frequency, low amplitude, but there are these big eye movements, but at the same time the patient is asleep, and the breathing is often irregular as you get these autonomic discharges in REM sleep. You can tell they're asleep usually because they're not responding to their environment. They've usually got their eyes closed, and they may well be snoring. So that's one of the ways, those are the ways one can tell. The other way is that the EMG, which is quite important, the chin EMG, which we tend to measure, shows atonia during REM sleep because the body is switched off, so that you don't act out your dreams. There's a special paralysis mechanism that descends from the medulla to the ventral horns and the anterior horn cells in the cranial motor nuclei. If we're thinking about pathological states of depressed or absent consciousness, in this case absent consciousness, depressed consciousness, we might talk about stupor. But coma, by definition, is a complete loss of consciousness. It's pathological, it's caused by some pathology. Although one does hear people speaking of medically induced coma these days, so perhaps that would not be considered pathological, obviously with anesthetic agents. There's complete loss of wakefulness and awareness. Wakefulness can be present without awareness in the persistent vegetative state, or the wakeful unaware syndrome, which we're going to talk about. But in coma, both of those are lost. There's unresponsiveness to external stimuli. Testing, as we talked about with the Glasgow coma score, the eyes are usually closed, but they can be open. And coma is often reversible. So, for example, after hypoglycemia, metabolic insults, or after a fit, postictal coma, and so on and so forth, or a brief blackout due to hypoxia or hypotension. Metabolic coma, for example, in renal failure or hepatic failure, particularly hepatic failure, often has these peculiar triphasic theta waves. These are slightly faster than the delta waves, usually between about 5 and 7 hertz. And they come in little groups of 3, and that's a sign, for some reason, of particularly hepatic coma, but can also occur in other metabolic comas. So the outcome from coma, as I said, it's usually reversible. There's usually recovery, but there can be neurological deficits depending on what's caused the coma in the first place. But the other outcome is if as coma recovers, it's quite common if there has been severe damage to the cortex for patients to go into this wakeful, unaware state, or the vegetative state, which I'll just briefly outline, which is basically where the brainstem is still working, which produces states of apparent wakefulness with eye opening, sometimes with eye movements, with also states of sleep. So you get sleep-wake cycles because the brainstem is partly involved in generating those along with the thalamus. And but the patient doesn't seem to be responsive at all to their surroundings. They don't seem to be aware, despite eye movements. The eye movements are not coordinated to what's going on around them. They're rather random, and you can't get them to respond to any input in any way. So, for example, painful stimuli in the visual field, trying to speak to the patients. There's no meaningful response. And then the other outcome of coma is where rather than the cortex being damaged, which is what happens with the vegetative state, is when the brainstem itself is damaged. And that means that the cortex can no longer be activated. And in that situation, the patient is said to be brainstem dead, provided you have gone through the appropriate tests, which we'll talk about. In extreme cases where the cerebral cortex is damaged and the brainstem is damaged, you get absolutely no response, with no sleep-wake cycle and no obvious cortical function, but patients very rarely survive for very long in that state. This is the Glasgow Coma Score, which you probably ought to learn because it will come up again and again. It's relating to assessment of the patient's response to stimuli in three groups. First of all, you look at the eyes, and particularly eye opening. Secondly, you try to alert the patient with verbal commands, and also with motor commands. But you're looking at their response to their motor response. Sorry, if we just look at the E, M, and V on here, it's the best eye-opening response, the best motor response, and the best verbal response. So these are talking about how the patient responds. So if they spontaneously opening their eyes without any stimulation from speech, then you give them the full score of 4. If they only open them to speech, it's 3. To pain, it's 2, and to no response, it's 3. You'll see that each one of these sections has a no response, which is 1. So you can't score less than 3 on a Glasgow Coma Score. That is the absolute minimum, and the maximum is 15. So it's out of 15. So we've got 4 in that group, in the eye-opening group, 6 in that group, and 5 in the verbal response. So moving on to the best motor response to verbal command, we're looking at the motor response. Sorry, it shouldn't really say to verbal command. I'm going to change that. It should say just the best motor response. So I will change that on the slide. In fact, I don't think I think we can actually do that now. No, it's not liking it, so I'm going to stop there. No, I am just going to pause the video for a minute and stop the share. Right, we're going back to recording now. Yes, I can't actually change that on there. I'll have to change it. So it should just say best motor response. And then we've got obeying command. Excuse me, is number 6. You get 6 for that. No response, you get 1. And then you can apply pain to the nail beds and also to the orbital ridges, and you can get various responses. If you see extension, and you might see extension on one side and flexion on the other side, you take the best response, which is flexion is generally better prognosis and indicates a higher level of consciousness than an extension response. These are due to damage at various levels within the nervous system. And no response is worse than an extensor response. Then we go to the best verbal response, and if they're orientated and conversing, they score the full 5. If there's no response, they score 1. If they're disorientated, they score 4. If they can't even use the right words, they score 3. And if they're just groaning without any comprehensible words, they score 2. Right, well, we've also already mentioned the vegetative state, or the unresponsive wakefulness syndrome, the slightly more PC term that's being used more and more now. So I've already said the patient appears to be awake, or they can be asleep as well, but they have periods of wakefulness generated by the brainstem. But because the cortex is damaged, there isn't any responsiveness to their surroundings. So they have preserved arousal, the sleep-wake cycle, that have absent awareness and hence consciousness, as far as we know. And there doesn't therefore appear to be any voluntary response to the environment, and there are variably preserved reflex responses. So you may get some doll's eye responses from the brainstem. You may you'll usually get pupil responses. So you get basically the brainstem responses. But if they're not, if they don't respond to pain, if they start to respond to pain, you're moving into the minimally conscious state, which is a kind of halfway house. The cause, I've said, is widespread damage to the cerebral cortex, and is defined as a persistent state if it's lasting for more than 4 weeks. The permanent vegetative state, it depends on the cause, and we'll come to that in a minute. But you can never be absolutely sure that it is permanent, and that can cause some problems. So if it's 4 weeks or more, then we can say it's a persistent unresponsive wakefulness syndrome or vegetative state. After a non-traumatic brain injury, which generally has a worse prognosis, then in the UK, if you've been in that state for 6 months, then we generally say it's permanent. And that can allow withdrawal of feeding and so on and so forth, according to discussions with the relatives. In the US, it's 3 months, and after traumatic brain injury, which has a much better prognosis and you can have surprising recoveries, we generally wait a year before coming to the conclusion that the patient isn't really going to recover. And I've already talked about this alternative terminology. This is the Royal College of Physicians Guidelines 2015. And I think we've already basically said that. Yeah, so if there's a bit of uncertainty about whether there's been some response, then of course you have to keep watching for longer. Right, the minimally conscious state, defined here as a state of severely altered consciousness in which minimal but clearly discernible behavioral evidence of self or environmental awareness is demonstrated. So if you get any of these things, consistent movement to command, object recognition, object localization, reaching, apparent bits of visual pursuit, following objects in the environment, like following a face that's moving around the room, fixation onto anything in the environment, same sort of thing. Some kind of motor response, manipulation of an object in the hands, localization to noxious stimuli. So if you basically stimulate with pain to a fingernail bed, for example, by squeezing a fingernail bed, the patient withdraws the hand in a way that looks to have a voluntary component rather than just reflex, which generally reflexes would be extension or flexion. So if you see a sort of pulling away from a painful stimulus, then you have to be suspicious that there is some minimal consciousness present in the patient and that they're not in a vegetative state. And again, the same with any vocalization that seems to be a response to the environment. Object use, functional communication will start to suggest that they're going to recover from the minimally conscious state back to some form of meaningful consciousness. This particular study, which was published in Science in 2006 by a group at Cambridge, Adrian Owen and company, basically they took a whole series of patients with what were thought to be persistent vegetative state, and they did some brain imaging, functional brain imaging, where they asked them to do two things. They asked the patient to imagine playing tennis, and then they did some functional imaging, and then they asked the patient to imagine going from one room to another in their house. And they showed that these, in some of a certain subset of patients that were thought to be in a permanent vegetative state, were in fact able to respond. And in particular, what they saw is that some of these patients who imagine playing tennis, just like fully conscious patients, would start to activate their supplementary motor area. And when they were navigating around their house in their mind, they would activate their parahippocampal gyrus and some other areas in the parietal and frontal lobes, the posterior parietal lobe and lateral premotor cortex, in a similar way that controls did, controls who were fully conscious. And this was quite shocking because it revealed the fact that patients who we thought were completely unconscious in a vegetative state were in fact at least partly conscious. But it's not a practical tool in the ITU, as you can imagine. And so people are at the moment trying to develop simpler methods, for example, near infrared spectroscopy to look at blood flow and so on in the brain, with instruments that can be used in the ITU. But at the moment, we haven't got any reliable test of minimal consciousness. So that's of interest and important to know about. The next thing you need to know about, and this could come up in the exam, is the locked-in syndrome. And this is usually due to damage to the anterior or ventral pons. You can see the high signal on MRI in this patient. And this is a post-mortem specimen with severe damage to the ventral pons. This is usually caused by a stroke, brainstem stroke, basilar artery thrombosis characteristically, or distal vertebral artery thrombosis in a dominant vertebral artery. And it knocks out the corticospinal tract up to the level of the brainstem, I should say up to the level of the midbrain. And what this means is that patients are not able to move their limbs voluntarily. They're not even able to speak voluntarily. Speaking obviously involves the medulla, which is the lower brainstem. they're not even able to move their eyes horizontally, but they have retained midbrain function, which means they can often open and close their eyes to respond, or move their eyes up and down to an extent. And these patients can be fully conscious, but because that's all they're able to do, can be mistaken for being unconscious. And if you're not sure, an EEG is often helpful, but careful observation and seeing if the patient can respond to questions in terms of their vertical eye movements or their eye opening and closing is important. There are other causes of the locked-in syndrome. One particular cause is a very severe Guillain-Barré syndrome, where all the motor nerves are damaged. And in fact, you can be completely locked in without even any vertical eye movements, but still be fully conscious. There's been quite a well-known book written about this condition, written with eye movements which were converted into text by someone called John Balby, I think his name was, French chap, who wrote a book called The Diving Bell and the Butterfly and died shortly after finishing the book, in which he described what it was like to be locked in. Not very nice, but actually, strangely, patients somehow often get used to it and adapt to it, and it isn't quite as horrific sometimes as you might imagine, but I think it's still pretty horrific. It can occur with, I think those are the two causes that you need to know. There are rarer causes of damage to the output pathways of the brain, but I think if you know Guillain-Barré and ventral pontine damage due to a basilar artery stroke, or just a stroke affecting the ventral brainstem or the anterior brainstem, that's what you need to know. The other thing you need to know about is brainstem death, because it's used as a criterion for death in the ITU, and this is where the brainstem is irreversibly damaged and so can no longer activate the cortex, and so there's no longer any chance of regaining of consciousness, which requires activation of the cortex by the brainstem. The way this is assessed is to look at the cranial nerves, and particularly to look at the reflexes of the cranial nerves. And we look at the pupil reaction to light, the caloric test, which is basically putting ice cold water in the ears and see if you get a deviation of the eyes, the corneal reflexes, response to pain that we've talked about, orbital pressure, and sternal rubbing as well are generally used. A response to poking something down the throat or waggling the tracheostomy tube to see if there's a gag reflex, or poking something down the throat to see if there's a cough reflex. And then finally, if all these reflexes are absent, doing an apnea test where the carbon dioxide is allowed to rise to 6 kilopascals. And what you do is you pre-oxygenate the patient, so the oxygen levels are as high as you can get, and then you switch off the ventilator and allow the CO2 to build up to 6 kilopascals. You wait 5 minutes, having pre-oxygenated the patient, and if there's no response no respiratory response, no respiratory efforts to the rising carbon dioxide, then the patient is said to be brainstem dead. But the test has to be repeated 24 hours apart by 2 physicians who are not working in the same unit. They have to be independent. This is just a pictorial way of thinking about testing for brainstem death. So we'll start at the top of the brainstem, the pupillary response, the light going down the optic nerve into the top of the brainstem and synapsing with the Edinger-Westphal nucleus to produce the parasympathetic constriction of the eyes. Then we've got oculocephalic movements, or so you can actually turn the head and see if the eyes move, or put, if that doesn't work, that's the so-called doll's eye movement. You then do the caloric, which is putting ice water in the ears. Then we've got the response to sound through the ears. we have got the corneal response, which goes through the 5th cranial nerve and is expressed through the 7th cranial nerve, facial blink. And then we've got the respiratory testing, which relies on neurons in the medulla. Right, I've already said there's got to be 2 people doing the test, 24 hours, 2 doctors, 24 hours apart. There's got to be the presence of something that's irreversible. I have actually once seen a patient who had very, very severe alcohol intoxication. They'd consumed 1.5 bottles of whiskey very quickly and came in with fixed dilated pupils, no respiratory movements, and all brainstem reflexes absent. And woke up the next morning with just a bad headache, having been kept on ITU overnight. So you can't make that diagnosis if you don't know the cause. So the cause, you have to have a known cause of brainstem structural damage, such as anoxic damage or a stroke or trauma to the brainstem, and so on and so forth. You have to have absence of all these potentially reversible causes, thinking about metabolic things as well as toxins and electrolyte disturbances, and hypothermia, not to be forgotten, and sedative drugs, and that's important with overdoses, etc. Then we have irreversible loss of brainstem function, confirmed by 2 doctors, taking place. We've talked about neocortical death. This is something that's really not used in the UK. It's an American concept, so I'm not going to talk any more about that. Right, let's move away from the medicine and back to a little bit of the science of consciousness. What in the brain is responsible for consciousness? Well, we've already talked about the cerebral cortex, the thalamus, the reticular activating system. But there are other parts of the brain that seem to be quite important, certainly for the usual contents of consciousness. And there are microscopic structures as well, which may be important, which I'm just going to briefly talk about to begin with. Stimulating with an electrode near the claustrum in a patient who was having tests for epilepsy produced unconsciousness quite reliably in this particular patient. And so there was a lot of interest in whether the claustrum, which has very marked connections between the back and the front of the brain, provides quite marked connectivity between the back and the front, might be responsible. And back in 2017, a team in America with Christoph Koch, who's very interested in consciousness, described these claustrum crown of thorns neurons in mice, which went all the way around the brain. Very, very big arborization, and crossed both sides of the brain, and speculated that these might be important. This was never really published properly in a paper and still hasn't been. So there's a little bit of skepticism about that. Then there are these big neurons which are only present in hominids, humans and great apes. And they're present in the anterior cingulate and the frontoinsular cortex, which are areas of cortex which pop up a lot in conscious experience in humans, or correlate activity in them correlates with conscious activity. They're the big, enormous neurons that provide very large or very distant connectivity across the brain. And it's thought that possibly linking distant areas of the brain may be important for consciousness itself. I'm going to actually remove that slide, because I think we've got another one coming up later on, so I'm just going to get rid of that. Right. We talked about the cerebral cortex being important. We talked about the thalamus, But there are two particular nuclei, the intermediolateral and the centromedian parafascicular nucleus, which seem to be more important than the rest of the thalamus. And if you stimulate these nuclei, you can again switch off consciousness or make people extremely drowsy. And these are where anesthetics are thought, particularly this nucleus, are thought to act. We've talked about the importance of the various components of the brainstem, the arousal nuclei, serotonergic, dopaminergic, noradrenergic, histaminergic, and cholinergic nuclei. That's just showing them in a little bit more detail. These are the so-called individual arousal systems, which are often neurotransmitter specific. The anterior cingulate gyrus pops up a lot in consciousness as well, particularly detecting of errors, a sense of volition, and also the conscious registration of pain. And it also seems to be important for social evaluation. And so that seems to be a structure that pops up quite a lot. We've talked about the claustrum already, yeah, that was that particular patient where the electrode was placed here, which was the claustrum is this structure. Actually, you can't see it very well here. This is the insula, but it lies between the insula and the putamen. There are physiological correlates. We've talked about anatomical correlates of consciousness. And we've already talked about the EEG when we were talking about sleep and slow wave sleep and wakefulness. And wakefulness seems to be associated with high frequency, low amplitude EEG patterns. And deep sleep certainly seems to be associated with high amplitude, low frequency, so-called slow wave patterns. And we've talked about the patterns in coma, the triphasic theta waves, and so on and so forth. Alpha rhythm seems to occur when you shut your eyes in a relaxed state, but is associated with consciousness. So its appearance on the EEG is always associated with consciousness. And then one of the things that's been found with more depth electrode studies in animals and correlating this with other features of consciousness is that there seems to be gamma high frequency, particularly in the 40 hertz range, activity associated or activity occurring between areas of the brain. So for example, between the visual cortex and the sensory cortex particularly, which seems to be associated, for example, with visual attention and visual consciousness and with higher functions. But we now know that, in fact, it's not always associated with consciousness and is perhaps more of a marker of attention than consciousness. Right, what do we got next? Resting brain activity and disorders of consciousness. Yeah, so disorders of consciousness, which include things like the minimally conscious state, the persistent vegetative state, and coma, if you group them all together and you look at functional MRI scans, and this was a meta-analysis of many studies, the area that seems to be most likely to be switched off in terms of reduced activity or reduced functional activity on functional MRI scans seems to correspond with the medial thalamus and to a certain extent with the left cingulate gyrus and certain other structures as well. The precuneus in particular and the posterior cingulate, and these latter two structures are part of something called the default mode network, which I'm going to come to in a minute. If we look at functional imaging studies of various conditions, if we look at the vegetative state, we've already talked about large areas of the cortex being damaged, but it seems to be a combination of large areas of the frontal and the parietal lobe. So you can probably get away with remaining conscious if you've damaged large areas of your temporal lobe, or at least having some form of consciousness. If we look at loss of consciousness or impaired consciousness in a complex partial seizure, again, we see this frontoparietal distribution this is activity in a seizure which switches off the brain or switches off normal function. If we look at an absent seizure, again, we've got this frontoparietal distribution. And again, the same thing with sleepwalking. This is one patient actually, and it was a technetium brain scan, functional metabolic activity, deoxyglucose technetium scan, where patients with sleepwalking compared with awake patients or the same patient when he was awake, the areas of the brain that were still switched off were the frontoparietal cortex. The occipital cortex had switched back on, and so the patient was able to navigate to a certain extent while sleepwalking, but was in a zombie-like state. They weren't, as far as we know, conscious. Certainly couldn't remember being conscious. I just want to mention that the way we tend to think about the brain these days, rather than just areas like Broca's area for speech or the occipital cortex for vision, is that there are networks active all the time, probably different networks and switching between networks involving multiple brain areas. And this is certainly very important for consciousness. And the frontoparietal networks, of which there are, depending on who you read and what papers you read, probably three major ones, which are the dorsal, the ventral, some people just separate the left from the right frontoparietal areas, seem to be particularly important for consciousness, but also something called the default mode network, or the DMN, which involves particularly the medial prefrontal cortex, which is an area that's very closely related to emotion and control of behavior, and then also the posterior cingulate and the precuneus on the medial surface of the parietal lobe, and the angular gyrus, which is part of the temporoparietal junction, which is an area that seems to be particularly important for body image and to a certain extent visual processing, as well as the memory areas of the brain. And these are all connected up in a network that is active together, statistically speaking, if one analyzes your functional MRI data. And these areas seem to be active during consciousness, but when consciousness is mainly focused on the inside world rather than the outside world. Activity in this area seems to correlate with activity in the other, in particularly the attentional networks, and sometimes there's a switching between it seems to be negatively correlated. So when this area is active, the attentional networks tend to be switched off, and there tends to be switching between one and the other, and that seems to be important for consciousness, and gets across the idea that consciousness is a dynamic process. That's just the functions of the dorsal, the proposed functions of the dorsal default mode network. This is the idea that in brain networks, that in disorders of consciousness, there is a breakdown in both often the default mode network and the executive control network, or the frontoparietal networks. Okay. And the breakdown in the connectivity between the two. So what about physiological correlates of consciousness apart from the EEG and the functional MRI scan? There are these things called event-related potentials, which are basically potentials which are recorded by averaging the EEG after repeated identical events, and then getting an idea that the brain is doing some post-event processing, usually 300 to 400 milliseconds after the event. And particularly, there's been a lot of interest in the P3, or short for P300A and B. The P3A seems to be particularly big if the stimulus is novel, and the P3A, and the P3B if it's unexpected. But both of these seem to only occur if the stimulus is reported. And if you do a paradigm where there's no report of the stimulus, then what tends to happen is that the P3A and P3B tend to be much smaller or disappear altogether. People are now talking about the N400, the late positive complex, which may be more important for correlating with consciousness. On the motor side of the brain, a voluntary action is usually preceded by a buildup of activity in the supplementary motor cortex recorded over the vertex, and that's of interest as well. This is a very interesting idea, and this is the idea that using transcranial magnetic stimulation in patients with various in full consciousness, and then in various states, for example, in patients with in coma or under anesthetic, and looking at what happens in the brain with the in terms of the EEG, or sometimes the MEG, the magnetoencephalographic signal. And what tends to happen is that in patients who are fully conscious, is that you get a very complex set of changes in the EEG signal, which spread from the area where you've stimulated with your transcranial electrode, and then spread over a period of time to far and distant brain regions. And I'm just going to see if we can play this on the YouTube. Just give me a second. I think we may have a little bit of a, oh no, we've got it. Okay, so I'm just going to move into this presentation. This is from a chap called Massimini. We need to get about 9 minutes into the presentation, which is about here. So the stimulation
this way. So in this case, we are now looking at the same data, but this is source modeling. So we look at the currents generated. We estimate the current generated in the brain by the perturbation. There's an initial activation under the stimulator, and then activity travels in an interesting way, which is global and differentiated in the
200 milliseconds,
and it lasts for about 300 milliseconds.
Changes in the EEG activity.
So this is the typical pattern of wakefulness. And you can summarize this in a snapshot by just painting on the cortex areas that were significantly active, latency is color-coded. So it's long-range, long-lasting activation, complex activity moving from one place to another. Now, subject falls asleep, entry, if you wake him up, it tells you, but the pattern of spatial-temporal activation is completely different. So what happens here is that the stimulator triggers strong activity, only the module that has been directly perturbed, and this activity does not propagate. So this sounds like a breakdown of integration.
And then once we get to about 170,
and it's also shorter in this case. And you can, plot it like this. Okay, so far this looks in qualitative terms like this, and in this case like this. It's modular.
So what that seems to be telling us is that the consciousness seems to be associated with more distant and more complex processing of signals that arise in any particular area of the brain. In this case, induced by an external stimulus. So that's interesting, and perhaps not unexpected, but it raises the possibility of having some kind of meter that can, as it were, measure consciousness, a consciousness meter. I think I just wanted to briefly state the importance of thinking about our perceptions as constructions rather than as pure representational data sitting on the surface of the brain. We tend to process our sensory information, and not only do we match it up with what we expect, but we often fill in. And so our conscious perceptions are to a great extent constructions with a lot of top-down processing, where we fill in what we expect to see, and provided there are no errors coming in from the perception or from the sensory organs, then the construction, as it were, is accepted. And you can see this with the so-called rubber hand illusion, which I haven't got time to talk about now. And you can also see it with inducing, for example, out-of-body experiences by getting people to wear goggles where they actually see themselves from behind, because the goggles are connected up to a camera behind them. And so the perception they get is that their body is in front of them, as it were, or in front of their eyes. And you can induce a kind of out-of-body experience, which is quite interesting. This just brings me on to the sort of finishing lap, as it were, to just talk about the various theories of how consciousness might be generated, if indeed it is generated as such by the brain, caused by the brain. And one of the theories which has been very popular since it was first proposed by Bernard Baars in 1989 is the global workspace theory. And this is the idea that consciousness arises as a result of distant brain areas being connected because of activation of pathways between these areas, and the strength of the activation determines the strength of the pathway. This has been further modified by Dehaene and Changeur in 1998, where they've tried to sort of map it to known neuronal processes. And they've come up with this idea of lots of individual subunits of the brain processing information unconsciously. But when the processing the input is very strong and links up with other areas in the brain, so for example, other inputs or other areas of the brain involved with perception as a result of previous experience, that consciousness is somehow arises as a result of these long distance pathways being ignited. The integrated information theory is a theory which is based, it's the main competing theory, although I think they overlap in some ways, but it's based on the idea that consciousness, the properties of consciousness is that it involves both integration and differentiation. In other words, if you look at if you perceive a chair, the conscious perception of a chair involves the ability to perceive the chair as a whole unit, but also to break it down into its individual bits, like the material on the seat, the arms, maybe parts of the arms and parts of the legs, and so on and so forth. So that in any one conscious experience, there is this ability to move down and to differentiate, and to move up and to integrate. And the ability to do both is mathematically modeled into some index which is called phi, and that this may by measuring phi, one may be able to somehow get a measure of how conscious things are, and it may be a way of understanding what consciousness is. There's quite a bit of debate about this theory, and I haven't got time to get into it now. There are quantum theories of consciousness based on the fact that quantum processing may provide something additional to classical Newtonian or relativist, or let's talk about Newtonian or standard ways of computation. And Penrose and Hameroff have come up with the theory that there may be some kind of quantum computation going on in the microtubules. Others have come up with the idea of a consciousness field, a bit like gravity in the universe, and that certain physical processes involve quantum processes at the very microscopic level, and that this somehow activates or produces patterns in the field of consciousness, and that therefore consciousness may not just be entirely within the brain. There's the idea that consciousness is not what you think it is, or it's an illusion, which I think is a crazy idea. But if you're interested in that, you can read Dan Dennett or Keith Frankish's book. Dan Dennett's written a book in the, I think it was the early 90s, called Consciousness Explained, or Keith Frankish's book, Illusionism. Then there's the idea that that partly actually fits with integrated information theory, in that consciousness is somehow present in all matter and energy in the universe, but that it gains its full complexity by a combination through complex circuitry and integration and differentiation and so forth. And the philosopher Philip Goff has written an interesting book recently called Galileo's Error about that. A slightly related idea is the idea that everything is fundamentally consciousness or mind, and that all matter and energy is just a manifestation of mind. That's a slightly crazy philosophical idea dating back to Bishop Berkeley, but there's a modern version of it by Bernardo Kastrup called The Idea of, written in his book, which is a series of papers called The Idea of the World. And then there's the concept that consciousness might actually just be a law that with certain physical processes there is consciousness, not that it's caused by the physical processes, but that it runs in parallel. And I'm just going to come back to that in a minute. And finally, we have the traditional views of consciousness, that consciousness is caused by something else, some other substance, the mind substance, which is different from the matter substance, the spirit, as it were, that is somehow inside or put into, perhaps by God, or in the traditional religious views. And that's called interactionist dualism. And that idea goes back at least to Plato, was popularized and defined by Descartes, René Descartes. But what I want to do is to just go back to the idea of how we can explain experience from physical structure. How do we explain the experience of vision and sound and emotion and memories and agency? How do we explain all these experiences? How do we explain experience at all, or consciousness at all, from the perspective of from the perspective of a physical structure, albeit with great complexity? And one philosopher called Jerry Fodder put it like this, that nobody has the slightest idea of how anything material could be conscious. Nobody even knows what it would like what it would be like to have the slightest idea about how anything material could be conscious. David Chalmers, modern Australian philosopher, has called this the hard problem of consciousness, the difficulty in basically getting mind from matter. And this is a nice slide that illustrates that idea. Can we just see that trick again? Bunch of neurons producing as if by magic, consciousness. And Leibniz, the 17th century, 18th century philosopher, basically he talked about the fact that if you had a machine like a perception machine, and he likened it to a mill, and it's known as Leibniz's mill, a machine that calls perception, even if you could look at every single part and visit it, you would never have anything, you'd never find anything that would explain the perception. And that perception or consciousness, which was the term he was using really to refer to consciousness, is not in the composite or in the machine, and you just won't be able to find it there. And however hard we look in the brain, even if we knew what every neuron in every the firing patterns of every neuron, we still wouldn't be able to explain consciousness. And that's an interesting idea. There are some other difficulties of consciousness, which I haven't got time to go into. But this idea that consciousness is not explicable causally in terms of material or the physical factors gives rise to the philosophical idea of psychophysical parallelism, which was first described by the Frenchman Jelinek. Sorry, he was Dutch, but he wrote in French, and he talked about two clocks being synchronized at the beginning, and that mind and matter just went in parallel with each other, and whatever happened in the matter, there was a sort of mental component or spiritual component. Leibniz had the same idea. He called it the idea of pre-established harmony. And John Hewlings Jackson, father of British neurology or English neurology, again had the same idea. He said that the states of consciousness, or synonymously the states of mind, are utterly different from the nervous states. That's the states of the neurons. Second, that the two things occur together, that for every mental state there's a correlative nervous state. And third, that although the two things occur in parallel, there's no interference of one with the other. This may be called the doctrine of concomitance. And he said we can't really take it any further than that. So I would just conclude by saying that however fine-grained in time and space the neural correlates of consciousness are, the explanatory gap between mind and matter remains. And this is called the hard problem of consciousness. And that's the end of my talk.